Good afternoon. Today we're going to talk about the ASOS-2 trial, which will be conducted in the next few months across Africa. The purpose of this presentation is to help you understand the background and importance of the ASOS-2 trial, how to identify high-risk patients using the ASOS surgical risk calculator, what the suggested interventions are to increase post-operative surveillance, and how the trial will be conducted. So background to the trial, the African Surgical Outcome Study, or ASOS, was a prospective observational study which recruited over 11,000 patients from nearly 250 hospitals across Africa. It found that approximately 1 in 20 or 5% of patients experienced severe complications or death, and approximately 1 in 5 or 20% of patients experienced a post-operative complication. This rate of complications is similar to the global average. What we found, though, was that in Africa the mortality rate after surgery was over 2%, and most of these patients died post-operatively. Most of the patients died due to unrecognized clinical deterioration and a failure to rescue after complications occurred. And so despite similar complications to the complication rates to the global average, African surgical patients were twice as likely to die after surgery. The most common complications in ASOS were cardiac arrest, surgical site infections, bloodstream infections, pneumonia, acute kidney injury, and post-op bleeding. Early identification of these complications may reduce mortality. So, 1 in 5 African surgical patients develop post-operative complications, and 1 in 10 of these patients die. So what caused this failure to rescue? In Africa, the number of surgical staff members is 20 to 50 times lower than the recommended minimum safe level. In Africa, we believe that these limited human resources are adversely affecting outcomes after surgery. So the main aim of the ASOS-2 trial is to determine if we reallocate the existing human resources to increase post-operative surveillance for patients identified as high risk, i.e. those most likely to experience a complication, that we may decrease perioperative mortality. Based on ASOS, a risk calculator was developed to identify patients at risk of serious complications or death after surgery. 6 risk factors were identified. These were the only independent predictors of serious complications or mortality in ASOS. The risk factors were age, ASA physical status, the indication for surgery, urgency, severity, and type of surgery. So to use the ASOS surgical risk calculator, points are assigned to the risk factors. These points are then summed, and the ASA physical status was found to be a stronger predictor than individual medical conditions. Gynecologic and obstetric patients experience fewer severe complications and death than the control group, and hence they receive negative points in the risk calculator. Increasing points represents increasing patient risk. Our high-risk patient is defined as having more or equal to 10 points. A score of more or equal to 10 means a patient is above the average risk for severe complications and death in Africa, and that's about 5%. On the right of the screen, you see different risk categories according to the number of points the patients get on the ASOS surgical risk calculator. So the hypothesis is that surgical mortality in Africa can be decreased by allocating existing resources to high-risk patients, as identified by the ASOS surgical risk calculator. Increasing post-operative surveillance in high-risk patients may help rescue patients who develop complications and thereby may decrease mortality. 5 interventions have been suggested which require minimal additional resources and may have a large impact in early recognition of post-operative complications. The study is a cluster randomized trial. Hospitals throughout Africa will be randomized into 2 groups. There will be a control arm who will receive standard care, and there will be an intervention arm. And in the intervention arm, all adult surgical patients will be risk stratified using the ASOS surgical risk calculator. Increased postoperative surveillance will be implemented for high-risk patients. The primary outcome is in the hospital mortality. So this is what the study looks like. All adults 18 years and older undergoing inpatient surgery will be enrolled into the trial. The sample size requires over 650 hospitals and over 665,000 patients. Hospitals will be randomized to usual care or increased postoperative surveillance. The increased postoperative surveillance arm will have patients stratified using the ASOS surgical risk calculator, and all high-risk patients will receive increased postoperative surveillance, with the primary outcome of in-hospital mortality. These are the interventions in the intervention arm. Admission to a higher care ward than had been planned at the time of surgery. Increase in the frequency of nursing observations in the post-op period. Assigning the patient to bed in view of the nursing station, as opposed to putting the patient in a remote location in the post-op ward. Allowing family members to stay with the patient in the ward in the post-op period, and a mandatory placement of a high-risk bedside guide above the patient's bed. This is what the high-risk bedside guide looks like. It identifies that the patient has been risk stratified as a high risk. It identifies that the patient needs increased postoperative surveillance. And it shows us the complications which are most likely associated with poor outcomes in these patients. And then there are suggestions on what one might consider doing if the patients deteriorate in the post-op period. Each local team will identify how to deliver these interventions for each high-risk patient at their hospital. Ideally, multiple or all the interventions will be implemented for high-risk patients. Placement of the high-risk bedside guide above the bed of every high-risk patient should be feasible at every site, and thus this is the only absolutely mandatory intervention. So in preparation for the trial, there are three phases. There's phase 1, which is preparation, phase 2, intervention when the trial is running, and phase 3 is the data collection. So in preparation, the site lead investigator establishes a team, and this team has leaders in different departments. The team works out how to perform the interventions and how the data will be captured. They work out the specific task for each member in the team at the hospital. In the intervention arm, the team will run a short test of the intervention prior to the trial to identify barriers to implementation. During the trial, during the intervention phase, there will be use of the ASOS surgical risk calculator in the intervention cohort to identify high-risk patients. And this will probably be performed by the anesthesia provider. If the patients are high risk, increased surveillance interventions will be discussed between the surgeon and the anaesthetist, and the interventions will be prescribed. On the post-op ward, these interventions will be implemented for all high-risk patients by the frontline staff. That's the nurses, ward staff, and surgical staff on the ward. And finally, all the data will be collected. Clinical investigators will record the data on a CRF or case record form, which will document which interventions were performed for high-risk patients. All clinical investigators will document mortality and complications on the CRF until the patient's discharged, or if they're still in the hospital, will be censored or stopped at 30 days. And the CRF will be uploaded into the electronic database. So in preparation for the trial, the site leaders need to undergo site initiation education, which is material similar to this. The site leaders will obtain institutional and other regulatory approvals necessary to conduct the trial. The site leaders will identify a local team, and we recommend that they need at least 2 people. One is based in theatre and one on the surgical ward, but ideally more people are important to implement the trial. We suggest that you consider team members from surgery, anesthesia, nursing, and management. We know that a strong local team is necessary for the success of this trial, and they will be responsible for the day-to-day implementation of the trial. The site leaders will explain to the local team using educational material, and the local team will educate the clinical health workers at their site or hospital. If you're in the control arm, the local team will meet and decide who will follow up the patients and who will record the outcomes. Posters will be placed in the hospital and the patient care areas so that patients know that the hospital is in a clinical trial. During the intervention phase of the trial or during recruitment, all patients 18 years or older who are having inpatient surgery will be recruited into the trial, and the patient data will be recorded on the case record form. For the control arm, this is what the CRF or case record form looks like. In the intervention arm, in preparation, the local team will meet and decide who will perform the risk evaluation using the ASOS surgical risk calculator. How will these increased post-operative surveillance interventions be implemented at their site? Who will ensure that the implementation of the interventions, and who will follow up with patients and record outcomes? Each site that's randomized intervention arm will then perform a 2-day test run where the ASOS surgical risk calculator and interventions for high-risk patients will be implemented. The objective of this test run is to identify barriers to implementation of the increased post-operative surveillance. And once these barriers are identified, the local team will work to resolve them. Posters will again be placed in the hospital and inpatient or patient care areas so that patients know that the hospital is participating in the trial. During recruitment, all patients 18 years or older who undergo a surgical procedure and spend a night in the hospital at the site will be evaluated using the ASOS surgical risk calculator. Patient data will be recorded on the case report form. Possible interventions for high-risk patients will be discussed by the team, usually between the surgeon and anaesthetist, and the interventions will be prescribed and implemented. This is what the case record form, or CRF, for high-risk for hospitals randomized to the intervention arm looks like. The data in the red block is the data necessary to calculate the score from the ASOS surgical risk calculator score, and to document what interventions were given to the patient who was high risk in the post-op period. So this is what the trial looks like for the control arm. So for hospitals in the control arm, they will record the pre and intra-op data on the CRF. In the post-op period, there will be a team on the ward who will complete the CRF with any interventions and outcomes on that patient until hospital discharge or death. And then these data will be uploaded onto the electronic database. If your hospital is randomized to the intervention arm, this is what the trial flow would look like. In the pre-op period, the anaesthetist would do the risk assessment with the calculator and record the risk factors on the CRF. Ideally, this would be done pre-op. But if it's urgent or emergent surgery, it could be done intra-op or even in the immediate post-op period. For the post-operative intervention implementation, the surgeon and the anaesthetist will discuss the interventions that should be implemented for high-risk patients and record them on the CRF. In the post-op period, the frontline staff on the ward, that's surgeons, nurses, and other workers on the ward, would ensure that the interventions are implemented, and they would record outcomes daily until hospital discharge or death. The data then would be uploaded onto the electronic database. The post-operative interventions will be documented on the CRF up to day 4 in the intervention arm. Post-operative complications and mortality will be reported daily until hospital discharge or death. The trial would end at a site at the end of the week in which the site has exceeded 100 patients. So, if at the end of 1 week a hospital has enrolled more than 100 patients, it would stop recruiting. If not, it would continue to a second week. If at the end of the second week it's exceeded 100 patients, it would stop recruiting. If not, it would continue in the same vein. If, however, after 4 weeks, immaterial of whether the site has recruited 100 patients or not, the hospital will stop recruiting. So no hospital in Africa will recruit for more than 4 weeks, and we suspect that the majority will recruit only for 1 or 2 weeks. It is extremely important that the data is recorded accurately on the CRF for every patient. If not, this will compromise the work of thousands of providers across Africa. It is vital that every team understands the importance of accurately documenting patient outcomes in this trial. Finally, the information on the CRF will be uploaded onto the online system. Each patient will receive a unique numeric code, so they will be anonymized, and they will be untraceable back to the patient without the local team. Data will be anonymized to which hospital it came from and evaluated on a continent-wide basis. The results of the trial will be published under the group name ASOS-2 Trial Investigators. So in conclusion, I want to thank you for participating in ASOS-2.